3 of the top 15 causes of death in 2007, almost 7 years ago, were neurologic in nature. So you've got these two words, prevalence and incidence. Prevalence is going to be the number of people in a given population with a particular disease. And then incidence is going to be how many people were diagnosed with this disease in 2007. And if you look in your book, it's just going to show you some big numbers on the different types of neuro disorders. And with these neuro disorders, we've got protocols, we've got treatment plans for a lot of them. But just like with your other medical emergencies, a lot of your treatments are just going to be supportive, right? When you get on scene and you have a patient that's got a neuro emergency, you know, there's going to be several things that may stand out, and then there may be things that don't stand out, right? You've got to remember that these patients, if they've got something neurologically going on, they're not in control of their body anymore, right? Their brain's not in control of their body. So we've got to be sure that we make this a priority, especially when it comes to the areas that affect the airway. So we know that our two main structures are your brain and your spinal cord. Then you've got your central nervous system and your peripheral nervous system. Stuff you've been seeing since A&P and all that. Your somatic nervous system, it controls your voluntary. Tells you to move your hands and all that. Then your autonomic is going to control those autonomic functions that we don't have to think about, right? If we had to think about beating our heart every day, if we had to think about breathing every day, then we're going to have some issues, right? So how does it process this stuff? Or how does the nervous system process what we bring in and tell our body what we take out? Or tell our body what to do? Well, if it's something that the brain needs to process, one of your senses, touch, feel, smell, something like that, it's going to come in through the nervous tracts and then it's going to be processed. All right? Take the ears, for instance. The ears hear sound waves. The nerves convert the sound waves into electrical impulses. Sends it to the brain, sends it to the hearing part of the brain. That's where it processes. Sight, vision, speaking, motor function. We've learned that each part of the brain controls a different aspect. What part of the brain controls the higher functioning? All right, so your front controls your like your emotions, your outbursts, things like that, affect. But what part of the brain as a whole, the whole unit? The cerebellum, right? The cerebellum. Right. Yeah. Got myself confused. So our occipital lobe, occiput, scans through the images, takes in the visual. Your temporal lobe, it attaches the image to a name. Your frontal lobe controls voluntary. Your efferent nerves, and this is stuff you've been hearing, your efferent nerves is the nerves from the brain, the spinal cord, to the muscles to tell it what to do, motor function. Your afferent nerves are the things that process touch, feel. Touch and feel are the same thing. And then your parietal lobe, it perceives touch and pain. Now these are going to be just on the very tip of the iceberg of what all the brain parts do. So you've got your frontal lobe. We talked about this the other day. Conscious thought, speech. Your parietal lobe, your temporal lobe, and your occipital lobe. And this is all part of what? The cerebellum. Battery's going dead. Your diencephalon and the brainstem. So what on a very topical view of the brainstem, why does the brainstem exist? Alright, so it's the connection between the spinal cord and the cerebellum. It functions for your autonomic stuff, but the main function for it is to control the autonomic stuff so that the cerebellum can function for its higher thinking, its higher actions, its higher processes, right? The cerebellum part can do all your emotional stuff, your hearing stuff, your sensory stuff, and the brainstem is for your autonomic control. The midbrain, the reticular activating system, that's part of your sleep-wake cycle. That's why all of you, or maybe not all of you if you've been on night shift for a long time, but for folks that function during the day, that's why you get sleepy at night and you wake up in the morning, your circadian rhythms, all right? Your pons, it controls respiratory pace and depth. This is important to remember when you start talking about head injuries and herniation, all right? Why do you think you get the Cheyne-Stokes breathing and the apneustic breathing? Because there's an insult to the pons, right? Then your medulla controls your blood pressure and your pulse rate. It also stimulates the drive to do what? To breathe, right? So your diencephalon is part of your hypothalamus, or is made up by your hypothalamus and your thalamus. What was important from your test about the hypothalamus? It's the connection between what? The endocrine and the neurosystem, right? So is the hypothalamus, is it part of the endocrine system? Is it a gland or is it part of the brain? It's part of the brain. It's part of the brain. But what it does is it controls the glands. It sends signals to the pituitary gland. Sends signals to it and tells it to release these hormones. Okay? Your limbic system generates rage and anger. Hypothalamus. Just talked about that a little bit. Controls your pleasure, thirst, and hunger. Has the endocrine function where it communicates to the pituitary glands. The pituitary glands send messages to the adrenal glands. The adrenal glands release epinephrine and norepinephrine. What has to be stimulated to tell the adrenal glands to release epinephrine and norepinephrine? The sympathetic nervous system. Then your cerebellum, it manages your complex motor activity. It's where you have learned behaviors. That's that deep memory, all right? That's where riding a bike is stored. You learn how to ride a bike using your frontal cortex, and then it's stored back in the cerebellum.
So we've been wrong. We're talking about the cerebral.
Yeah. We were wrong. I was wrong. It was a... Yeah. I know I was wrong. Another reason why I don't want these recordings to be out on YouTube. Not that any doctor is going to sit the time and listen to little old me, but you would, just so that you could make fun of me. So how do they communicate? How does the brain communicate? It's through the neurons, and it transmits the impulses. Neurons contain the cell body, the axon terminal, and the dendrites. Now, what surrounds the axon? Well, I jumped ahead just a minute. Hold that thought. So, your synapses is a gap between each cell. How do we get that impulse to go from here to here? Through your neurotransmitters, right? Your neurotransmitters. Some of your neurotransmitters are going to be dopamine, acetylcholine, epinephrine, and serotonin. So your axons, they're coated with myelin. The myelin insulates it. Now, once that myelin is started to be degraded and goes away, is it reproduced? No. That's very important to remember when we get into some of the neurologic disease processes. So it's just a sheath around the actual axon itself. What that does is it helps insulate, and it helps keep the conduction of the nerve system in a forward motion. You lose that myelin sheath, then you lose the ability to control the nerve impulse. You can go back and read over this chart. Two things that the brain needs a constant supply of and does not have a storage for. That's oxygen and glucose, right? The brain is very sensitive when it does not get oxygen and glucose. The brain, however, is resilient to internal environmental changes. It does have the ability to compensate, but it can't compensate for very, very long. One thing to remember with your neuro stuff, with your scene size up, is that there are some neuro diseases that are caused by contagious infectious diseases. Be sure you always have your standard approach. We talked about the basic information in the case study. Definitely want to get an overall view of the scene. Now, what's going to tell us if this patient is stable or unstable? All right. So, a lot of the same things as if a cardiac patient is stable or unstable, but we're going to rely a lot on neurostatus as well with these patients, right? What is one sign of changes in the neurosystem with this patient, or one sign that it's getting worse? Level of consciousness, mental status is changing. All the things you see here with your general impression. Of course, we're going to be concentrated on the best pre-hospital care, but you need to get this information because it will follow the patient through. Naturally, the airway will have some effect on your airway and breathing, even the mechanical aspect. All right, even if it doesn't hit like the pons or the medulla, if you lose the ability to control your airway, to keep your airway open, then you're going to have issues with obstruction. Now, something that you may see in a patient, especially if he's got a seizure, head injury, or cerebral hypoxia, is trismus. What is trismus?
Clenching of teeth.
Yeah, clenching of teeth, kind of almost like a lockjaw kind of thing. What is that going to present? Or what issue is that going to present you with? Airway, definitely. Definitely. Used to, if a person having a seizure was clamped down, they had this thing called the airway cork, or the airway screw. And it was just basically, it looks like, well, I'm not going to tell you what it looks like. No, I'm not even going to draw it because y'all are going to start laughing. But anyways, it's this thing that's kind of pointed at the front and then it gets bigger. It's got a little handle on the back and you're able to turn it and it's supposed to help pry open the mouth. Alright? But we know with seizure management, we let them finish the seizure before we do anything, right? We just protect them from injury. Ensure oxygen, 94-95%. Provide routine hyperventilation only to those patients with documented unconsciousness. Not real sure with that, but signs of increased intracranial pressure if we start having signs of what? Herniation, right? Remember, what does oxygen do? Vasoconstricts, and so it helps reduce some of the swelling in the brain. All right? Again, here's these respiratory patterns. Why would you have like chain stoats or biotes or apneustic respirations? Because the pons has been damaged, right? In the brain stem. Hoping it'll work. Has anybody ever seen somebody with agonal breathing or chain stoats breathing? Weird respiratory patterns? Maybe. Maybe not. have to come back to our videos. I really want to try to see this. Alright, well maybe we'll just come back to it. See if by chance this works. Nope. Definitely anticlimactic here. Alright, let me move forward before somebody falls asleep. Had some pictures or some videos of them actually doing it. It's actually quite interesting. What is the ideal mean arterial pressure for to maintain cerebral perfusion? 60. Once you start getting increased intracranial pressure, you have signs and symptoms that are almost opposite of shock, right? You've got a decreasing pulse rate, decreasing or irregular respiratory rate, and an increased blood pressure. That's called what? Cushing's reflex. So we're definitely looking for our posturing, the weird respiratory patterns, things like that. Definitely want to keep the blood pressure. With a head injury, we have to keep it a little bit higher than our normal permissive hypotension, right? Because it takes a little bit more pressure to perfuse the brain. We've talked a good bit about increased intracranial pressure and trauma, so we're going to move on. Some of the things that needs to go into your transport decision. If you're in Alabama, it has to be what? The stroke system. You've got to call the stroke system. There's no ifs, ands, or buts. Well, if your region's participating in it, let me rephrase that. Our region 6 is participating in it, but I guess by Brian shaking his head, the Chambers region is not. Okay? Okay. I think that it's going to be mandated by a certain time that everybody's got to be part of it. Now, we don't participate in the trauma system. But basically, they're both operated out of the same command system, and it's pretty much the same thing. You're just going to answer different questions. Part of the calling the stroke center includes doing that thrombolytic checklist. They've got a list of questions, and then they will ask, where is the patient wanting to be transported? First time that I put it in, I was scared to death because I was talking to Henry about a week before, and he had put a lady that had some very, very, very mild symptoms of stroke. She was just, she was walking alert and all that, just had a little facial droop, a little weakness, and she just wanted to go to East Alabama. Well, he called the stroke system, and they said, oh, East Alabama's on diversion. They're not taking strokes. You're going to have to fly her to Montgomery. So they actually had to land the helicopter in this lady's front yard. She walked over and got on the helicopter, and they flew her up to Montgomery. So I was a bit nervous about that. The guy that I called, he was definitely having a big time bleed. Yeah.
If your region's not participating in it, does that mean you can't call, or does that mean you don't have to call?
You don't.
If you wanted to use the resources, could you use it?
I've called them twice, and if I transported the patient to East Alabama, they accepted the patient. But if I was transported to a hospital not in the stroke system, they would not let me put them in the system.
Yeah, I think it depends
So once
on.
they let me in, once they didn't.
Yeah, so that would be like if we were trying to put a patient in the trauma system and East Alabama's not participating. And basically what it does is it just streamlines the process. It keeps that patient from having to go to the ER and sit around and wait and wait and wait. They've activated the stroke system. They're waiting with CT, MRI, or whatever. And so if the hospital's not participating, it's not going to really do you a whole lot of good to do it. Thanks, Brandon. When we're doing our history, we want to find out, is there an explanation as to why, especially like in seizures. Seizures can occur from numerous things, right? But if a person has a history of seizures, most often it's because either they didn't take their medicine or their medicine levels are getting off, right? But if you've got an adult patient especially that's never had a seizure, and now they're all of a sudden experiencing seizures, we need to see if we can find the reversible causes. Definitely want to get your sample history. And then do a good assessment, especially if they're on the ground. I don't think we need to spend a ton of time on this because you should know how to do it. Look for ptosis. I believe that P is silent. Dropping or sagging or prolapse of a part of the body, most often manifested in the face when it's a neuro. What could this indicate? Could indicate stroke, right? If I saw somebody looking like that when I walked up, I'm going to be thinking stroke. But it could also indicate Bell's palsy as well. Well, your level of consciousness, just because somebody is awake and speaking doesn't mean that they're alert and oriented. Or doesn't mean that they're oriented. Just because a person's looking around in their environment doesn't mean that they're oriented. There's many variations of your level of consciousness, and you need to be able to determine at what level they are. Obviously, with the unstable, that's where we're going to be completely unresponsive, posturing, things like that. Your AVPU. P, response to painful stimuli. What's the most common thing that we jump to? The sternal rub. Sternal rub's not necessarily accepted anymore. All right? And despite what anybody tells you, if you do a sternal rub one time and they don't wake up, if you try to do that sternal rub again and touch their backbone, they still ain't going to wake up. If you've ever had somebody just messing around with you, it don't feel good. You're going to try to get them away. But other things that they say to do now is apply gentle fingernail pressure. Take you a pin, just put it there, and that hurts. I'd rather you rub my sternum, I think. Grab a little bit of that old arm fat and pinch that. That's pretty, the old sweet meat. Also, you can apply pressure to the supraorbital foramen above the eyeball. Just whatever. And I've heard it called noxious stimuli because giving somebody painful stimuli carries a poor stigma. Now, if a patient responds to painful stimuli with posturing, we're thinking what? Some type of head injury, right? Spinal cord injury. Your Glasgow Coma scale. Let's do a couple real quick. Open up your book to the, if you don't have it memorized, open up your book to the Glasgow Coma scale chart. What page is it on, somebody?
Got it on the slide.
Yeah, but I forgot. I don't want to go back to it. 31-year-old male is acutely intoxicated with alcohol. When you arrive, he immediately makes eye contact with you. He does not know where he is, but can tell you his name. You ask him to squeeze your fingers. He attempts to grab your hand, but starts crying because he can't find your fingers. What is his GCS? All right? Eye opening. That's a 4. Verbal. 4. Why? Yeah, he's disoriented. And then motor. I'm going to give him a 6. He's trying to do what I'm telling him to. He just doesn't have the coordination to do it. Does that make sense? So what would y'all give him? A 14. So that would be mild. 24-year-old female has been ejected from a vehicle. Her eyes are closed, but she is moaning with and without stimulation, and all extremities begin to flex inward when you try to elicit a pain response. What is her GCS? So, eye-opening. 1. Verbal. 2. Moaning, incomprehensible. Motor. What are y'all saying? 3. Alright, so that's going to be a 1, 2, 3, 4, 5, 6. 8 or less is critical. That lady has a head injury. 13 to 15. Now, we're not supposed to diagnose with intoxication, but if you pick up that kid from the Sky Bar that smells of whatever kids these days drink, and he's got poor coordination and slurring speech, you can almost bet your bottom dollar that he did not have a stroke, right? Well, your orientation, this is where your alert and oriented times 4 comes in. Now, when those of you that we went through the actual systems assessment, I still haven't got to do that with everybody. I kind of told you, you want to be kind of careful with that, because some patients may go through the motions of knowing what their name is. All right, I've had patients that could tell me their name, but couldn't tell me anything else that's going on. I've had patients that could tell me their name and their birthday, but couldn't tell me anything else that's going on. And then we talked about it just a minute ago. Some patients, if they don't really need to keep up with time, date, and all that, they may not know and be perfectly oriented. All right? Another thing that you can do, a little technique that I've learned to do, is if you've got family around, ask the patient kind of a personal question that only a family member or somebody that knows that patient would know, like, what's the name of your dog, or what's the name of your granddaughter, or something like that. All right? And of course, confirm it with a family member, but you know, that way you could at least get a little bit of a better idea of their cognition. Does that make sense? And then we know what confusion may indicate when we're thinking neuro, you know, hypoxia, decreased blood pressure, things like that. Now, some patients, depending on the type of neuro disorder that they've got going on, may experience hallucinations or delusions or psychosis. And some of these patients, and we'll get into this a lot more when we get into psychiatric illnesses, may be on medication to help manage that. So your hallucinations, these are sensory impressions without external stimuli. Y'all see that purple elephant? Well, if y'all see it, then y'all are crazy like me. All right, so there's nothing there that would even indicate a purple elephant in the corner of the room, right? So that's what a hallucination is. I'm seeing visual things, but there's no reason for it to be there, all right? Illusions. These are stimuli that may be misinterpreted. Y'all see this cobra right here? So I may be under an illusion that this is a snake instead of actually a cord, all right? And then delusions. The delusions. I'm the king of America and I make multi-million-dollars every day. That's a delusion, right? You got to be very careful with these patients. When I did clinicals, especially when I did a lot of psychiatric nursing clinicals, and we'd spend a whole day with these patients, sitting doing group therapy and just talking to them and all that. Shoot, after about 8 hours of hearing these delusions from them, I couldn't interpret what was real and what was not. You know, I mean, I was giving this guy my number because he owned a multi-million-dollar company and he was going to give me a yacht. What's important about hallucinations and illusions especially, and we're going to get into this more, but I just want to throw this in, is that we don't buy into them, right? No matter what them older medics may tell you, you don't buy into them. If they see a snake, you reassure them that is not a snake. I'm scared of snakes. I wouldn't be touching that if that was a snake. That is just some cords. Or, you know, if they keep getting scared because that purple elephant's coming to sit on their chest, then you need to tell them there are no purple elephants in here. It's just me and you. Ask a patient how easy it is for him or her to think. Not a great question, because at 5 o'clock on Tuesdays and Thursdays, you ask me that question, you ain't going to like the response, because I can't think good after so much thinking all day long. Corneal reflex. This isn't pupillary reflex. Now, it's something that we'll check, but corneal reflex. It'll determine intact cough and gag reflexes. They're all on part of the same nerve tracts. They're saying tap between the eyes, and the patient should blink. All right. Another test that they may do is to snap. She's got good corneal reflexes. I saw her. You may want to snap, or this picture right here is one that they would do. They get a cotton, just a little bit of cotton, and just kind of touch the cornea and see if they blink to get it out. All right. If they don't do any of that, you've got to assume that they don't have an intact cough or gag reflex either, because all these reflexes are part of the same nerve tract. And then your cranial nerve functioning, you've got your cranial nerves that each one may be doing something different. It may manifest as different signs or symptoms. You've got your olfactory, your optic, your oculomotor, trochlear, trigeminal, abducens, facial, auditory, glossopharyngeal, your vagus, your accessory, and your hypoglossal. Go in and know these, all right? I want you to know these. You should know cranial nerve 10 very well, because we talk about its effects in cardiology. One way to remember it, and if you Google ways to remember cranial nerves, there's a lot of really perverted and dirty ones that I wasn't going to put up here. But on old Olympus' towering tops, a Finn and German viewed some hops. Do what? Some people learn about mnemonics. I just always uttered out the ooh ta fagba. That was the way I always remembered it. I don't know how, but that's the way I always remembered it. These are in order of from number 1 is olfactory and number 12 is the hypoglossal. Assessing speech. Agnosia. Agnosia is the inability to name common objects. I have a video, but I'm not even going to try because it's let me down. Agnosia, the way that they'll test, like in a clinical setting, is they will take they'll take a card. Let's just say it has a lock on it. All right, that's what the video says. Tell me what this is, and it'll be a picture of a lock. And this patient has to get into some deep thought, and then he's like, a car or a tree. And then they would go back and say, okay, let me help you narrow it down. Is this a clock? Is this a lock? Or is this a car? And then they would have to keep narrowing it down. All right. This agnosia is problems. Is particularly frustrating with these patients, because that guy that's doing that test may look at it and may see a lock, and he may think a lock. But when his mind processes it and sends it to the speech, he can't get lock out. All right? So that's why it's so important for you to understand the different areas of the brain, because by looking at the symptomatic issues, you can kind of see what area of the brain has been affected. And then apraxia is the inability to know how to use objects. What was the example of apraxia when in the case study we just did? The pen light, right? When he took that pen light and he thought it was a razor. Okay? So the way you tested these, you just show them the object, get them to give you the name. If they respond correctly, ask how to use them. Receptive aphasia is the inability to understand speech with ability to speak clearly. They can talk to me, they just can't process what I'm telling them. And then expressive aphasia is very, very frustrating for a patient. I've had a stroke patient that was on his wit's end because he cannot speak clearly, but he can understand what he wants to say. He can understand everything that I'm telling him. So I'd ask him, how do you feel? And he'd say, car or tree, when he's really trying to say fine. And then global aphasia is an inability to follow commands or answer questions. All right? They're the ones that are just kind of looking at you. All right? Now, just because they can't follow commands or answer questions doesn't mean that they can't understand what you're saying to them. All right? You've got to be very empathetic and very patient with these patients. Hemiparesis and hemiplegia. Hemiparesis, weakness of one side of the body. Hemiplegia, paralysis of one side of the body. And then decussation is a crossing of nerves as they leave the cerebral cortex. And depending on what part of the nerve has been affected, you may have this weakness. So the arm drift, that's where we're checking for hemiparesis and hemiplegia. All right, very important to have them close their eyes. All right, that way they can't really focus on their arms with their eyes. It doesn't take a lot of thought to hold them up, but if they're weak on one side, then that arm's going to drift down. With your gait, we may look at walking patterns, the inability to walk, the inability to be coordinated. A lot of this will go into your motor function. And then a couple of new terms. Bizarre movement. Myoclonus is a rapid jerky muscle contraction that occurs involuntarily. Where do you think we would see this most often? Seizures. And then dystonia. This is where a part of the body contracts and remains contracted. A lot of times you'll see dystonia as the after effects of certain antipsychotic medications and things like that, but they may actually be like this and hold this posture for a very, very long time. All the muscles are rigid, and that's not the only pose that they'll strike, but you may have alterations in smooth motion, the real fine motor. You'll see tremors. See that when they try to grab something, with your intention tremors or your postural tremors, when a part of the body is required to maintain a particular position. Who do you think, what type of patients will we see tremors in? Parkinson's is a big one. And then seizures, you have your tonic and your clonic. All right, your tonic is rigid, and then your clonic is where you're shaking. All right. Paresthesia, that's numbness, often seen with hyperventilation, but also when you start having nerve tracts messed up. And then anesthesia is same thing as anesthesia with medications, no feeling. All right. And our blood glucose level, vital signs. We've talked about this. We definitely want to keep an eye on their core temperature. Even though we don't have a thermometer, we can feel their skin. We can tell if they're getting too hot. Why are we worried about core temperature? Because that may indicate that we may have some hypothalamus involvement, right? Because that regulates your temperature. All right?